With a glow of the screen and a heart full of pride, he's talking with experts from the world far and wide, broadcasting his voice through the good and the grand, on YouTube, Facebook, LinkedIn, and X across the land. Every Saturday morning, he's the urology man.
Hey, good morning, everyone, and welcome to UroNurse. I'm your host, Vic Senese. Glad to have you on board. If this is your first time checking us out, be sure to check out our website at uronurse.com, the best place to go to learn more about the show. We've got all of our past episodes. This is episode 172, so there's a lot of past episodes to check out. Also, you can listen in your car if you're on your way to work, got a long commute, maybe even a short commute. You want something to listen to? The audio version comes out every half hour after the show goes off the air, and it's available all the time through your favorite podcasting things such as Spotify, Apple Music, or Apple Podcast, Amazon Music, all those places. Also, we have our great sponsors. You can get to their websites real easily through uronurse.com, so be sure to check that out. This week, I've got a great show for you. I have today, I'm honored to welcome Greg McKettrick, a highly experienced compounding pharmacist with over 35 years in the field. Greg has dedicated his career to personalized medicine, helping patients achieve optimal outcomes through customized therapies. This session, he will share his expertise on the science and success of penile rehabilitation after prostate cancer, exploring how tailored treatment approaches can make a meaningful difference in recovery and quality of life. So please join me in welcoming Greg McKettrick. Greg, welcome to the show.
Thanks, Vic. Glad to be here.
So why don't you just tell us a little bit about how you got involved in all this and why you decided to do this?
Absolutely. Thanks for the opportunity, and thanks for everybody who's joining in. So again, I've been a pharmacist for a very long time. I always laugh because I tell people, hey man, I predate Viagra. So, I've been doing this for a while, but through the course of my career, I have worked in a lot of different aspects in terms of pharmacy. So I've been in hospital pharmacy and nursing home and retail. But most of my time I've spent in compounding pharmacy, which had a lot of attraction for me because if you're not aware, what compounding pharmacy really allows is for, finding solutions for individuals' problems or unfilled needs. And through compounding, a lot of times we can come up with solutions for problems that just aren't commercially available. And that can be a huge benefit for patients. Over the course of time, I did a lot of consultations, whether that be for hormone replacement therapy or ED or any other of the compounds that we would do. But I gravitated towards a lot of working with the men and really felt a strong pull, a lot of empathy just because of the situations that I saw. And, as a guy who's gray and balding and I've certainly seen my share of years, being able to relate and really empathize and feel what these guys were going through was an important part in my career. And because of that, I think I started to become very effective in terms of counseling patients, and that caught on. So I was getting a lot of referrals from urology clinics. A lot of times when they just didn't know what to do anymore, they basically kind of run through their menu of treatments, and not the point where they're going to, throw the baby out with the bathwater, but at least they were going to try and get some advice. So they started sending patients for consultations, which morphed into really more than just the consultations. It was training on penile injections and vacuum pumps and auto injectors and on different forms of therapy, and really looking at what the individual's personal situation was, what they had tried in the past, what comorbidities were involved, and then coming up with, hopefully the best therapeutic path we could. And again, as this kind of rolled through and momentum was picked up and I was seeing more and more referrals, something that really popped in my experience and started to see a lot more were guys coming in and they were post-prostatectomy patients, post-prostate cancer. And just the similarity in their stories, the Obviously they go in, they get diagnosed, which anytime anybody says the C word, that's traumatic to begin with. But then they kind of get herded through the process. They're gone in, they can do their biopsy, they're set up for treatment. And unfortunately, a lot of times after the treatment, the follow-up just isn't as robust as it needs to be. In some cases, there's really very little that's done for some of these guys. And I had so many that approached me in that situation. I really felt compelled to jump in and do something more, and started doing a lot of work with the online prostate cancer support groups, hopefully doing some good by answering questions and maybe offering some input in terms of the alternate treatment regimens that could be put in place for a lot of these folks that had kind of not been able to find answers. So again, after doing this for a period of time, it just struck me that there had to be a better approach. And whether I was really the perfect individual to take that on, I didn't know, but I sure as hell wasn't going to go without trying. So I consulted with a lot of the urologists that I work with routinely and got some input. And after that, decided, well, I'm going to sit down and try and figure out if there's not a way to put together a comprehensive treatment plan. So doing research, obviously going back through what my own experience had been, and then going through and seeing, what's the tried and true methods, what aspects of a, post-prostatectomy treatment or rehabilitation game plan really fit. And based on that, I wrote the protocol and then published it, and then went online and started to really circulate it. I was doing podcasts and webinars. I was actually sharing it with other compounding pharmacies around the country and coaching them on how to work with patients. In the end, ended up doing more just working with urology clinics all over the country. And, when I authored this, I was working out of my pharmacy that's in Charlotte, North Carolina. But we were acquired by a large national group called Revelation Pharma. Now, this just elevated the platform. It put us up to where we had just much better access to patients around the country, giving us the opportunity to really extend the breadth of the service and make this available on a much broader scale, which was great. And again, as I said, as things started to build up, it became slightly hard to manage the scaling process. So that's when I really kind of took the next step with this, and we developed a resource website for patients. Now, before I get into that, what I'd like to do is talk a little bit about what I deem as appropriate in terms of the post-prostatectomy rehabilitation protocol. My game plan with this was always to try and get guys in prior to going in for any form of treatment. I wanted to be able to start working with them while they still had continence, so we could, really focus on pelvic floor muscle control, familiarize with them with the muscles while they could still manage, and then progress through after treatment. I will tell you, in all honesty, I probably get 95% of my guys after, and sometimes well after they've gone through treatment. I always appreciate when I get them in early, but by the same token, that doesn't mean that if they come in after they've gone through, whether it's surgery, radiation, or a combination, doesn't mean that we can't still make a lot of progress with them. So typically the game plan with my protocol is, we get the guys referred. We try to do a very, very in-depth initial intake survey with them, because I have to know what their history really is, way before prostate cancer. What are the comorbidities? Were they having issues as far as sexual dysfunction prior? And, where is their current situation? What type of surgery or treatment did they have? Do they have nerve sparing or not? And, where are they in terms of their erectile function and continence at this point? Now, based on that, we kind of have some basic starting points that we really use across the board. So we try to get everybody on a daily tadalafil, a 5 milligram tadalafil, and a really good dietary nitric oxide supplement, which Vic and I were talking about this before the recording, just so for clarity, there's different types of nitric oxide. Nitric oxide is extremely important for overall metabolic function, but circulatory function, certainly. And it plays a huge component in ED therapy, how it marries up with the PDE5 inhibitors. And, it's actually the activating molecule for the cyclic GMP. So the good thing is it's easy to get. The bad thing is there's a lot of different versions and they're not all appropriate. Majority of the products on the market are amino acid based, L-arginine, citrulline, that sort of thing, which if the guys are under 40, those are phenomenal. They're great. That's in every pre-workout powder and all the rest of that stuff that folks take. And it's probably in the nitric oxide up at GNC or at Walgreens or CVS. Unfortunately, L-arginine has to go through a conversion process called nitric oxide synthase. This is the pathway. And that pathway becomes unreliable after the age of 40. So using that amino acid-based product with a patient who's over 40 probably is not the most efficient. That's why we use the dietary. So there's a number of different versions. There's beet and spinach, potassium nitrates. Arugula is my favorite. And I say that simply because arugula is oxalate-free as opposed to spinach or beets. So if you've got a patient that has any predisposition to kidney stones, you certainly don't want to aggravate the situation. Enough said about that. But we do put patients on the nitric oxide supplement with the tadalafil right out of the gate. We want to maximize blood flow and circulatory function. A lot of the guys come in and they think, oh, well, this is going to cure ED. I'm like, well, that's not really the purpose of that at that point in the process. It's just to get good blood flow going. So once their catheter comes out after prostatectomy, we initiate that right off the bat. Once they have healed up a little bit, we get them on a routine of Kegel exercises, which obviously we have training videos. We've got information on that, and we really kind of impress upon them the importance. Now, for a lot of guys, we will use our database of pelvic floor physical therapists. We have a network nationwide, and we actually have a locator on the website that I'm going to show you here in just a minute that helps the guys find a pelvic floor physical therapist in their zip code. So we will couple those in terms of the incontinence exercises. And then about a month after the catheter, we initiate physical therapy using a vacuum erection device, a vacuum pump. And I typically ask my guys to use that pump a couple of times a day. And the routine I recommend is to pump up, get a full erection, hold it for 4 minutes, relax that, let it deflate for a minute, and then repeat. So in total, it's about 10 minutes. I ask 10 minutes in the morning, 10 minutes in the evening using that pump. If they can do it a third time in a day, great. If not, so be it. So after,
I just wanted to ask you on the you mentioned that with the vacuum device that the physical therapy is doing that. So physical therapists are the ones teaching vacuum device.
Actually, no, we use that because I would love it, and I try very hard to partner with physical therapists so that they would be able to use that. We have the instruction videos, we have the guidelines and the training on the website for that. And the brand of pump I use, the Encore pumps, I have for probably a dozen years. They're reliable, they work, they're warranted, so it's nice and consistent for my patients, and it gives them a lot of options. So that is all on my website. So it's really a matter of just going to the site and they can watch the instructional videos, and then we talk them through this also. And to be honest, Vic, I talk with every one of these guys, not only on their intake, but then we meet with them every month. So while we're going through this process, I will literally walk them through how to use the pump, or if it's a Kegel instruction, we literally go through and spend the time so that they do understand these things. And then, like I said, on a month-to-month basis, we meet, we go over all of their progress, what successes they're having, where are they as far as the incontinence, and are we seeing any return of natural erectile function? And then based on that, we send soap notes back to their doctor, their care team. So they're always in the loop. They always know exactly what's going on. But what it does is it gives these guys that extra contact. They have somebody they can talk to. that's, you know, not intimidating, not coming at them in a white coat in a cold exam room, right? They can basically talk to me about anything that is happening, even if it involves, you know, intimacy in the relationships. You know, really, we try to be there. And, you know, I'm not a psychologist, but I will tell you that there is a lot of these conversations that probably border on, you know, that kind of counseling, just because
people just need support afterwards. They've got questions and they're just not always getting the answers.
Exactly. And, you know, as we mentioned, you know, in addition to the website and the protocol, I also do a lot of speaking with the zero cancer groups. So same basic element there. A lot of these guys, they're well down the path, but they still have a million questions and they just don't know how to get it answered. So being a resource.
Now with the Kegel exercises, you said you start those right away. Do you do that pre-op? Because I was always a big plus for, I thought pre-op was the time to teach this.
And exactly, that's what I said. I try to get these guys referred in prior to they go to any kind of a treatment.
Yeah.
That component is a little out of my control. So, you know, I say probably about 5% of the guys that get referred in, I get before they go for any treatment of the cancer. Majority of them I get after. And, you know, sometimes it's 6 months after, sometimes it's a year. I've had 10, 12 years post-prostatectomy guys getting sent over. So, you know, it's just, you got to meet them where they are in their path.
Yeah.
Ideally, you're 100% right. Ideally, while they have continence, that's when we want to get them in. That's when we want to start working, because we want to establish muscle memory, and they can really focus on that when they have the continence, as opposed to afterwards when they're trying to achieve continence again.
Yeah.
Yeah, you're 100% right. What I'd like to do is just kind of show this site, because the number one thing about it, there you go. This is in all respects just a resource for patients. It is something where we can get guys in here and they can get answers. And, you know, like I said, I did part of this simply out of the necessity for time and scaling and being able to work with the number of patients that we see. The other side of this comes from the necessity to get good information. I can't express how disheartening it has been on certain instances when I have someone who gets referred to me and they are actively trying to, you know, find answers on their own, and they're going down through Google. And I've actually had a couple of guys get so despondent from the information that they found online that they did bodily harm to themselves. You know, I had one guy got drunk and ran his car into a tree, and his wife showed up the next day and apologized for him missing his appointment, but told me that she was bringing him directly from the hospital because she kind of explained the whole scenario. So the point to this is that there's good information on this site. There's training, there's instructional videos, there's stories, there's information from immediate patients. Boston Scientific has their ED Cure and their Hard series on this site. All of that information is contained. Zero Cancer has their information on here, as do other of the partners that I work with. I don't know if I can, Vic, I don't have control of the screen. Can you click on resources for me?
I don't think I have control of that screen either.
Okay.
It's on your side, because it's wherever you pulled it up. That's where it should be controllable. Yeah. Do you have two monitors, or it's a single monitor?
Let me stop sharing for a second, and then I'll get back into it again.
When you're sharing your screen, you should be able to control it.
I've got it now. I didn't have full screen. So
what
I really want to show, first off, just to navigate through this so you guys can see what's involved in this site. And again, keep in mind, this is a resource page for patients. There's really not anything on here about, you know, prescription therapies, anything to that effect that they have to do. They can contact if they have questions, but what they are going to see are a lot of options in terms of what are available therapies that they can try. In addition to that, there are instructional videos. So, you know, we talk about supplements, we talk about anorgasmia, premature ejaculation. but also how to do penile injections, how to use a vacuum pump, what are different forms of medications like the sublingual troches or rapid dissolve tablets, and even going up into the penile implant, because obviously some guys end up going that path. But in here, we have a very extensive video library that covers a lot of these pieces of information. And then, as I mentioned, we have testimonials, and we also have information from a lot of our partners. Like I said, Boston Scientific, Zero Cancer, Gainswave, the Bush Center, if anybody's interested in the Tulsa Pro procedures. So again, just good information where guys can find it all in one spot. And then, as I said, as far as the training part, so in here we have in our resources access into the video library, which in and of itself gives you a lot of choices in terms of how to do different types of injections, how to do penile injections. There is a full overview of the full protocol, but here you can see there's a video that goes through step by step on how to do penile injections. Same thing on vacuum pump. And, Vic, you were talking about, who do we use for training? I would love it if we could get the pelvic floor physical therapist to actually, work with the vacuum pumps. I think it's a great fit for them, but at the same time, we just don't see it that much. So we have all of the resources that are there. They're easy to get to. Mm-hmm. This is something, and in fact, we typically will drop off with, whether they're with the support groups or with the urology clinics. We've got a lot of marketing information there where these videos and everything can be queued up with simple little QR scan codes that are on the table tents and posters and whatnot. So try to make this as readily available. And again, keep in mind, this is just an information source. This is not something where anybody's paying to get in here. There's no necessity to register. All it is open material for guys so they can learn and get good information instead of, again, like I said, I hate it when everybody uses Dr. Google and they get the worst possible scenarios.
There's a lot of information out there, and you're exactly right. It's just how do you know what's good information versus just junk out there?
So, through the course, and Nick, I'm sure, you see this a lot. One of the things I mentioned, I think the component of just having somebody to talk to on a regular basis. Mm-hmm. And this goes for both the patients, for the guys and their partners, because a lot of times we will actually have both partners on the calls when we're doing the consultations. And it really helps because there's a lot that gets, I think, just miscommunicated, and especially if there's been a long duration after the cancer and we were kind of dealing with lack of intimacy and lack of sexual function over an extended duration of time. A lot of times we have to work on reestablishing intimacy with the couples and really educate them on, what can be done and how the other resources. And to that end, I actually have a sexologist that works with me, licensed, education, trained, so that those kind of issues can be addressed. So we try to be, I'm not going to say we're the Walmart of penile rehab or anything, but we try to give as much information in one area on one site and make that available to the patients. And like I said, this is something that we've been doing for a number of years. The protocol has been used urology clinics around the country now. And the great thing about it is the success that we've had. We've definitely seen increased return to function much quicker than what we normally would. We see from the urology side of things, again, this is the impact on the clinic. Obviously, our benefit is for the guys, but the impact on the clinic is substantial too, because this is freeing up staff in the clinic so that instead of working with this, which is obviously very important, but it takes time and it takes resources. So if the clinic doesn't have to answer these phone calls and they're able to work on, maybe more immediate issues with patients than counseling on rehab, that allows them to have, better reach. We see better patient retention. We see faster recovery. In some instances, this actually feeds more surgical referrals back into those clinics, simply because obviously there's some guys that incontinence, we aren't able to resolve it through pelvic floor physical therapy or the Kegels, so they may become a surgical candidate for a artificial sphincter or a sling. And then, as I mentioned, in some cases, guys either kind of run through the gamut of available therapies for the ED, or they can't use some of them, and they end up going down the path of the penile implant. The nice thing is what we try to do is incorporate as many really effective treatments along that pathway as possible. So as I mentioned, we start everybody on the tadalafil and nitric oxide, and that's just, again, really to generate blood flow. And then we're using the vacuum pump. But then when we meet on a monthly basis, based on their progress, this is where we start to make some recommendations in terms of what therapies might be advantageous for that patient. So in older times, and maybe patients get converted straight from PDE5 tablets into a penile injection, which is fine, but we have some more aggressive oral and sublingual therapies, combinations of PDE5s, combinations that actually impart more from the central nervous system stimulation, things like apomorphine, to really stimulate the initiation of the erectile cascade, plus stimulate and generate a little libido, oxytocin, again, sexual function, desire, couple that again with the PDE5s. And if we can get a response without having to do injections, then we're heroes, and that's a wonderful thing. If we can't, then we can migrate up into the penile injections, which again, commercially very limited in terms of what's available. Your Edex or your Caverject, which very effective, convenient, but as Vic and I were talking earlier, they're expensive, and if you can't get it authorized, they can be basically economically just unattainable. So through compound,
let me just ask you to clarify a couple of things. So the monthly consultations that patients have with you, is this done virtually, or are they coming in to see you in an office?
Now I'm working with patients all over the country. Again, when I was localized out of one facility, it was primarily in office. Even at that time, we had folks just due to geographical limitations that would do virtual or telephone visits. Yeah. Now these visits are, I'm still in the Carolinas, but I'm taking care of patients that are all over the country, whether that be Texas or California or Oregon or Maine, Chicago.
Probably the only good thing that ever came out of COVID.
I think that it's a good thing, knock on wood, because unfortunately I spend my whole day in meetings and Zooms and all the rest of it. It's a great resource for these patients, though. This is something where we can actually work with them face to face and really make sure that they're getting the message when we're talking with them. So again, like I said, it really allows us to migrate the patient through this pathway. And I explained to every single patient when we talk, this is not a quick turn the switch and things are fixed. This is a path. This is a whole comprehensive game plan that we're going to follow. I call it building block therapy, because as we start out, it's very basic. We're using the PDE5, the nitric oxide, the vacuum pump. And then as we progress through and we're starting to see some return of function or return of sensations, we initiate other medications that just layer in up to and including the penile injections, which, even with that, I will tell you, quite frankly, I think I probably have about 150 different formulas of penile injections that I would use with patients. And you think, well, why? Well, because you've really got to focus on the individual. When I'm doing this, I'm looking at all of the components that are mixed into that injection. What is the effect that we need based on the patient? Is it more firmness? Is it less discomfort? Is it more duration?
Right. So some of the chemicals are more irritating, others are less irritating. Now, my other question for you is, so the patients have made a consultation, we've talked to them, and you decided on a role of therapy. Where are they getting their tadalafil? Where are they getting their nitric oxide?
So we always make it available to them. We have obviously pharmacies around the country that can do that, but by no means are they shackled to use me or my pharmacies at any point. Because the protocol itself involves prescription medication, it is a prescription referral. So that initial consultation and the initial supply of tadalafil and the nitric oxide is included along with the vacuum pump. So that's in one lump sum. That all comes to them. And when they pay for that, in addition, that covers all of the consultations that we're going to go through for the follow-up months. So if they choose to use a different pharmacy after that, that's up to them. If they want to use us, we can certainly facilitate that for them. And, we try to make sure that pricing wise, we're very competitive.
Gotcha.
Yeah. And like I said, everything comes with it. So it's kind of a one-stop shop, but because like I said, it is a prescription process for a lot of guys, as we make the recommendations, especially if it is something that's going to be not commercially available, then they'll generally follow along. And when we typically have a pharmacy that's within geographic reach, that they can be serviced by one of our pharmacies to actually receive the compounded products, be very difficult for them to, try and find on their own. If somebody's going to do a combination sildenafil, tadalafil, apomorphine, sublingual troche, they're not going to find that at their CVS or Walgreens or their grocery store pharmacy. So for a lot of them, it's just simpler to kind of stick with this process, and we use a pharmacy that is able to service them.
Okay, so that makes a lot of sense. So now the prescription is their provider has to get the prescription, or you're able to do this for them?
Well, the initial referral, obviously, when someone's getting sent in, most of the time they are coming to us from a urology clinic.
Mm-hmm.
We do have a telehealth portal within Revelation Pharma. So, and again, this stemmed out of the necessity because, unfortunately, for best efforts, there's times when we do consultations and we're submitting the recommendations back to patients' physicians. And then from that point, we kind of lose control of where the prescription went. Did the doctor approve it? Did they even receive it? Was it sent to the pharmacy that can provide that service? Or did they do something completely different? And what we ran into a lot of times, we talked to the patient, and 2 weeks after the consultation, they hadn't received anything. So then we started backtracking again. So because of that, we initiated the telehealth portal, which allows us to do consultation, and then basically immediately that prescription is generated and we know exactly where the pathway is. We can do it either way. If the patient has a physician that they're working with and they're comfortable with, then we absolutely are going to go that route.
Yeah. And they're screening for things like patients that are taking nitroglycerin products, things that would be contraindicated with the PDE5s.
Right. So that's all comes into the initial. I have, which I'm sure you're familiar with, the SHIM test,
right?
Sexual health inventory for men. I modified the SHIM test for my intake survey. It goes a little bit deeper, gets a little bit more of their longstanding history, allergies, comorbidities, and any medication therapies that they're using. So part of our initial intake with these guys is usually about an hour long, when we're going through explaining all the steps of the protocol and how we're going to work with them. And, basically that we're here as a resource for them at any point they can reach out. But again, that survey is first and foremost probably the most valuable piece of information that we get when we initiate this protocol.
Okay, very good. So I get a couple of questions that have come in here.
Yep.
So can you explain how compounded PDE5 inhibitors differ from commercially available versions, and why they may be preferred for the rehab protocols?
So number one thing, commercial tablets are great. Obviously, the greatest thing about them is they're dirt cheap anymore. But the negative to any tablet is the process that it has to go through to become biologically available. So you look at a tablet. Let's talk about sildenafil first. So, take it an hour before, but take it on an empty stomach, because I still tell you, even though it's been out since 1998, the number one misunderstanding for patients is, they got to take this especially without fatty food in their stomach. But,
right.
The people will tell me, hey, I failed on sildenafil. So I ask them, when did you take it? Did you have an empty stomach? And they look at me like, no, I took it after dinner.
Exactly.
So that's a negative. The other negative to that tablet is, as I said, it has to go through the digestive process. So it goes through the gut and the intestines and into the liver. First pass metabolism, right? Well, first pass metabolism eliminates a third of that drug before it hits the bloodstream. So that 100 milligram sildenafil tablet becomes something like a 65 milligram dose. The difference between the tablet versions and sublingual troches, number one, rate of absorption. So typically a sublingual dosage form versus an oral dosage form gets absorbed about 4 times as fast. That's a lot when it comes to convenience. Second, they don't go through the gut. So there's no interference. You can go out to dinner or lunch or breakfast, whatever your time of day when you're sexually active is. You can use a sublingual troche after, and it's still going to absorb. You're still going to get the effect. Thirdly, since it doesn't go through the gut, doesn't go through the liver, it doesn't go through first pass metabolism, which means you're getting a higher dose available directly into the bloodstream faster and easier and more conveniently. So that is, in a nutshell, the difference between the sublingual and the oral tablet. The deeper dive is that when we're compounding these things, we can incorporate multiple active ingredients. So instead of a single ingredient tablet, now imagine we're going to use a combination of a fast acting and a long acting PDE5, sildenafil or vardenafil with tadalafil. Now we get something that gets in the system and the bloodstream very quickly, is very active, very, very fast. The fast acting, whether it's vardenafil or sildenafil, they give you about 4 hours of activity. But that tadalafil component now you're chipping in, and it is going to do a little bit extra because we get better receptor coverage by using the 2 PDE5s, but we also play off of the characteristics of the individual medication. Tadalafil stays in the body and can be effective up to 36 hours.
Right.
So now, boom, 1 dose, and that Friday night dose is carrying through Saturday. That's an easy explanation of that part, but then we get into deeper dive. So what if there's other components of the disease state or the condition that we need to address? So, what if there's low libido? What if there's anorgasmia? We'll use a D2 dopamine agonist like apomorphine. And no, it's not an opiate. It's a dopamine agonist. It stimulates in the hypothalamus at the initiation of the erectile cascade. So this, from the central nervous system side, is actually helping to provide erectile function. Plus, you get a bit of a dopamine surge from it, so a mood and libido.
Mm-hmm.
Tie that in and add in oxytocin. Now you've got, this is the cuddle hormone, right?
Right.
So it's a neurotransmitter, but it stimulates both erectile function, orgasmic function, and that's both men and women, but mood and satiety, sexual satiety. So you can literally use 1 dosage form and achieve. So now we've got a PDE5 mixed into there, like a vardenafil in there. So we get the blood flow and sexual response. Hopefully they're on their nitric oxide, which really boosts, and I'll explain that in just a second, but that boosts the effectiveness of that PDE5. You've got oxytocin, you got apomorphine. So you're really maximizing what the potential benefit is using a single dosage form. Now imagine trying to do that from commercial products. You just can't. It's not possible.
And how do these size up compared in cost? Nowadays you can buy, Viagra, tadalafil, all these things over the counter, and I mean not over the counter, but dirt cheap.
Right. So the nice thing is the troches really aren't ridiculously expensive. Majority of them, and if you're familiar with a troche, it's a scored kind of a gummy, so it can be divided. Depending on what troche it is, it would represent anywhere from 2 to 4 doses. So that 1 troche is going to be about $10. And if you get, again, if it's a tadalafil troche, I make my tadalafil troches 75 milligram, and then 1/4 of that. And again, keep in mind the difference in bioavailability. So 1/4 of that 75 milligram troche has higher bioavailability than a 20 milligram Cialis tablet. Right. Same thing with a vardenafil. So again, a lot of times these things, you might be looking at, $2.50 to $5 a dose. But effectiveness, convenience, really the bandwidth of the effect that you can achieve by using this combination product is so much greater
that's
than
intriguing, is the combination of those drugs.
Yeah, and even just the dosage route, the route of administration, because amazingly, a lot of guys for their best intent, they just can't get the dosage, the timing right. A tadalafil tablet, God, I wish that they worked in 30 to 60 minutes, but in real practical world, it takes a few hours for them to really peak in the system. So I can't tell you how many guys would call up and like, hey, I took my tadalafil at 9 o'clock at night, but I didn't get an erection until 3 a.m. Like, well, okay, yeah, that's one that doesn't work quite as quickly. And
that's kind of the benefit of the daily tadalafil.
Exactly, the spontaneity, right?
You can just have that spontaneity. Plus, we were talking a little bit earlier. There's been a lot of good research out there, and I talked on my show about it for heart disease prevention, for stroke prevention, and for some mental diminished mental status protection.
Cognitive function, respiratory function, immune function, circulatory function, GI health. Obviously, they awarded a Nobel Prize for the work that was done with that. So again, you couple that with, like I mentioned, and I'm going to explain it just briefly here, I always tie in the nitric oxide. And as I mentioned,
why don't you go into that? Because that's an area I've never put together with adding nitric oxide in.
So, the functionality of a PDE5 inhibitor, I think we all understand, that blocks the enzyme that really attacks that cyclic GMP. Cyclic GMP is the molecule that's really what's allowing for the smooth muscle relaxation and arterial dilation so that we can get the erection. So, you take the PDE5 inhibitor, allows us the cyclic GMP to have a longer duration of effect in the body and promote erectile function. What is less well understood is that cyclic GMP requires an activating molecule, and that is nitric oxide. Nitric oxide, by the age of 40, our natural or endogenous production drops to about 50%. By 50, it's about 35%. By 60, it's about 15%. So if you are depleted in nitric oxide, and then you take a PDE5 inhibitor, you literally don't have the gas in the tank to activate the cyclic GMP. So the effects, and this is primarily why, we see guys that get put on Viagra after about 5 years, the response really diminishes. Well, if you think about it, they were probably already depleted of nitric oxide when they started on it, and 5 years later, it's even worse. Not to mention that as we watch this depletion of nitric oxide, the correlated effects that come with that are more vaso-occlusive disease, arterial plaques, circulatory function, blood pressure issues, which all can be addressed and benefit by using the nitric oxide. So there's a multitude of reasons. The main thing is we've got this little three-legged stool: PDE5 inhibitor, cyclic GMP, and nitric oxide. You take any one of those legs off and that stool does not stand up. Same thing, the erection won't stand up. So we do that a lot, and I mentioned the difference between the nitric oxides, the amino acid version, just not efficient for guys in the demographic of patients that I'm treating, mostly over 40 years of age. So we use the dietary forms, which the one that I use, that I carry, it's a arugula base, so it's oxalate free, doesn't trigger any kidney stones. So again, very effective for any age group, but specifically for the population of guys that I see majority of the time.
Yeah, I was just looking, some of the other things that nitric oxide, besides the pill forms that you can take and the dietary things, is just exercising more can boost your nitric oxide. My favorite is dark chocolate and red wine. Those are other.
There you go.
But I think that's one of the things that gets overlooked because, as you said, we've seen this all the time. People would suddenly say, I was getting great erections with that Viagra pill, but it doesn't work anymore.
Right. Yeah. Again, you typically get about 5 years. So interesting story. And again, compounding pharmacy, obviously, when I introduced nitric oxide back a dozen years ago or so, I had studied it. I had read about it. I had sat and met with urologists and professors, and we really talked about how we could incorporate this. But at the time, I was using these amino acid products and didn't see a whole lot of bang for the buck. As soon as I switched over to dietary nitric oxide, literally kind of shot myself in the foot, because now I had guys who were taking a daily tadalafil with a nitric oxide, a good nitric oxide supplement, and they didn't need the troches and they didn't need the penile injections. So yeah, we were taking care of a lot of guys, and I went from never selling commercial tablets to having 200 bottles of tadalafil on the shelf at all times, because the demand was so high. So we saw a tremendous response and benefit from incorporating the nitric oxide into therapies. And then, we actually carried that over when we went through COVID. We used it for a lot of our COVID patient therapies as well. But for this, it was absolutely essential.
Yeah. And, we're our own worst enemies a lot of the time, because we're just not active enough. We're not eating a great diet. And I think that hopefully some of this is going to change, because there's more emphasis now on dietary and definitely on trying to exercise. I mean, people want to live longer and have a good life. You've got to get up and move.
Well, and it is, they talk about the sad American diet. And as we talked about a little before we started recording, I always approach guys, and when I'm having this conversation, I said, hey, we can boost your nitric oxide levels through your food intake. So, let's look at this map of all of the nitrate-rich foods that you could be eating. Bok choy and arugula and spinach and beets and cucumbers and boom, 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 boom. And the guys look at me and they go, I ain't going to eat that. So, okay, you're going to take 2 capsules of a supplement a day, and we'll do it that way. Anymore, it's probably a heck of a lot cheaper just because of the cost of fresh vegetables and all. But again, if we all ate better, I'm always surprised when I'll do this and I use a salivary nitric oxide test strip with folks, part of the intake. And I'll get some guy who comes in, he's 85 years old, and I'm like, oh, I know he's going to be completely deficient. He's not going to show up anything. And he'll blow that test out of the water. And I sit there and look at him and say, you eat farm to table or what? I said, oh, yeah, I got a big garden in the backyard every day. This is all I'm eating. I'm like, okay, great. Yep. You're good. Thanks. You're doing exactly what you should do.
Yeah.
But again, a lot of this, just the conversation and being able to let guys know that there's options. And then, I don't say I'm holding their hand through the process, but I'm definitely lending them an ear and letting them, voice any concerns and frustrations. And I think that is a huge component, because just letting them know that there's somebody there that's going to help, that's going to give them some options goes a hell of a long way.
I'm going to grab another question here, because I think this is a good one to talk about. Many urologists incorporate combination therapies, which we've been talking about, PDE5 inhibitors, intracavernosal injections, and the vacuum erection devices. Now, you've been getting a lot of experience. What do you think is the best combination to go with? Everything or space?
So,
one,
as I mentioned,
and that and this, or
and what I said, I call what I do building block therapy. So, what are we doing? We're starting out with the PDE5 and the nitric oxide. We are 100% incorporating that vacuum pump. Why? Well, number of reasons. One, we know post-prostatectomy that within 4 to 8 months, you start to see penile atrophy. So you're getting this atrophication of the tissue, which is going to make
the fibrosis effect from lack of erection. People don't realize that's why men get erections in their sleep.
Right. So the benefit of doing this is to make sure that we don't have that. We're preventing the atrophy. We're maintaining the health of the tissue. But in addition to that, that process also lends to stimulating the nerve bed. So as we're going through this process, we are maintaining the health of the tissue, maintaining healthy blood flow. And then, like I said, I meet with them every month. So on those monthly appointments, we evaluate what's going on, and then we start to incorporate the next steps. And that next step might be doing that penile injection, or if they're starting to show some good return, we might try the troche first. So I am all in favor of incorporating this, and you have to look at this on an individual basis. If I just gave you a blanket answer that, yes, that's the perfect thing, I'd be shooting everybody in the foot, because you have to individualize care. Not every patient is going to follow identical pathways. we have kind of these points along that path in place where we're adding these different components in therapy and changing it. And then of course, changing the formulas if necessary, but the mindset is the same. What we're doing is we're tailoring this based on the progress of the patient. So am I going to incorporate all of this? Absolutely. Is that for every single patient? Absolutely not. But it's available to all of them if they need it.
Yeah. I think those are a couple of good points you brought out. We always recommended post-radical prostatectomy patients get on a PDE5 immediately. Not even, question whether they're having return or not, or whether you did a nerve sparing technique or not. Get them on that right away because you have to preserve the function.
Yeah. Well, and, one of the things that I found early on was that in a lot of cases, guys were getting prescribed sildenafil right after, which obviously it's effective. It's a great PD5. The problem is that why would you use something that's going to last for 4 or 5 hours when you have an option that stays in the body all day long? And that's why we basically will put everybody on that tadalafil just because of that.
Yeah, I thought early on in my career when all these were just because like you said, you've been around before Viagra, so was I. Yeah. And as they started evolving, I thought, well, wait a second, this one makes the most sense because of that long half-life. I can utilize that to my advantage by having patients on a low dose and they're getting up to whatever dose they need. And really successful with patients. And as you say, you don't have the same issue with whether you're taking it with the meal or not, because it's just always building up those blood levels.
Right. Exactly. Yeah.
That was really a great discussion. I think the other thing that, nowadays, unfortunately, the urology visits are patient, the urologists are busy people. There's probably not enough of them to go around for the number of baby boomers and everybody else who's now, hitting into that medical system. So having somebody that can spend the time with you is really key because these are not quick visits. This is something I did most of my career was I had an impotence, every Friday was my impotence clinic. And, but I had the ability, our practice offered that, and I could spend a half-hour appointment just going through stuff with patients, but the urologist can't, they're too busy. It's a 5-minute, out the door and on to the next thing. And I think that having these resources.
That's a huge point and a key point. And, if that's, again, I mentioned some of the different marketing pieces that we've developed. And to be honest, it was not my idea to do it. I was in a meeting with a large group of urologists and we were talking about this. And, obviously as we're sitting there, like, well, this is great. But just like what you just said, they're like, man, I got a stopwatch and it's 8 minutes from the time I enter that room until I have to be out. I can't introduce all of this on an 8-minute visit. I have to check all my boxes. I got to make sure that I'm updating their chart. I'm doing all of this while I'm talking to them. They said, but if the patient triggers the question, if they bring up the point, we have to answer that. We're obliged to respond. So that's when we started doing these posters and things. Is, are you suffering from incontinence, erectile dysfunction, post-prostatectomy, bum, 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 bum. Because if the patient sees it and then they point and go, I want to talk about that. Now that stopwatch gets paused so that there can be a conversation. But to your point, they're still not going to have the amount of time that's necessary to really go through all this. And by partnering with the offices, what we're doing is we're allowing them to incorporate really the better quality of care and taking care of these guys so that they don't fall through the cracks, so that they're not in that population that's, 10 years post-prostatectomy, no erectile function, still wearing Depends, their relationships falling into the toilet. This is something that, again, I've taken a great interest in. It's been a passion play for me for a number of years. And, just the I guess the edification of really enjoying what I'm doing and seeing the benefits in the patients and knowing that this makes a difference. It ain't never going to make me rich, but it sure helps my soul.
Yeah. When you go into this stuff. And most of us didn't go into it for the money. We went into it because we cared about people. And
Sure.
it's, I retired this past summer, so I'm not seeing patients in an office anymore. But I also got 5 podcasts that I relate with patients with. This one that's designed just for patients. One that's kind of a news story that goes through the research every week for the healthcare workers.
Yeah.
And then I have a friend of mine who's partially retired now, who's a sex therapist. And so again, we're trying to just deliver this material that we're so used to helping patients out that we still want to help. And we get a lot of great feedback from this program and others about how much of a difference it's made in their life. And I think it's just that people know this is a good source to go to and that they're getting quality, evidence-based information, which is important. So I really appreciate you coming on and talking with us today. It's been a fantastic talk. I'm going to put a little promo for next week's talk.
Is Peyronie's disease genetic? A groundbreaking new test called Peyronie's gene aims to answer that question. Join Vic, host of UroNurse, in an in-depth conversation with Landon Trost, MD. Dr. Trost is a leading urologist and Peyronie's researcher. Together they explore how genetics may play a key role in understanding Peyronie's disease. They also discuss how this knowledge can help in managing related sexual symptoms. Join us on November 22nd at 9 a.m. Central Time.
Yeah, looking forward to that one. Landon Trost has been on our program a couple of times, and he is like the expert in Peyronie's. And talk about a part of urology that's a small field. Peyronie's is definitely one of those that your specialists are very few and far between. And he's got some new thing called the Peyronie's gene that they can actually look at to figure out who may be prone to having this and what's going to need to be treated. So
yeah. We see a lot of patients that come in with Peyronie's and, both in the acute phase and the chronic phase. So we certainly have some therapies that we use, coupling different techniques, vacuum pump, and then medications to actually dissolve and soften those plaque and the fibrotic bonds. So, yeah, I mean, it's phenomenal because it can be completely debilitating for patients.
Oh, absolutely. So, all right. Well, thank you for showing up and coming on the show today. It's been a pleasure, and we'll see everybody next week on Euro.
So here's to the mornings, the coffee, the monitor glow, to the wisdom he shares and the folks that he knows. Saturday is special when Vic's on the stream with 40 years of knowledge and a head full of dreams.